When a highly volatile, life-threatening biological threat infiltrates a human host, the immediate danger rarely remains confined to a single patient. The pathogen seeks to multiply and spread. In January 2026, the World Health Organization published a disease outbreak news report detailing an emerging viral cluster in West Bengal, India. The index cases were two young healthcare workers, both nurses in their 20s, operating out of the same private hospital in the North 24 Parganas district. The pathogen responsible was identified as hain virus Nipah, or the Nipah virus. Medical science currently has no licensed vaccines or targeted therapeutics to deploy against it. This chart illustrates the case fatality ratio of the Nipah virus. It ranges from 40 to 75%, a lethality rate that towers over standard viral baselines. Compounding that lethality is the virus's incubation timeline. It can harbor silently in a host for anywhere from 3 to 14 days before any clinical symptoms manifest, giving it a wide window to move undetected through a community. Indian health authorities traced over 190 close contacts of the two infected nurses, testing colleagues, family members, and community contacts. Exactly 0 tested positive. Aggressive structural interventions physically blocked the transmission pathway, ensuring that all 190 contacts escaped infection by this lethal pathogen. Understanding how to contain the virus requires tracking it back to its natural environmental reservoir. Fruit bats, specifically the Pteropus species, act as the primary biological host. They carry the virus naturally without suffering any clinical symptoms. These bat colonies are geographically distributed across the coastal regions and islands of India, establishing a permanent ecological risk zone that intersects with human populations. The risk is seasonal. Exposure predictably spikes between December and May. The transmission vector is remarkably specific. During these months, human agriculture relies on open clay pots to collect raw date palm sap. Bats access the same sap, contaminating it with infected saliva or excreta. Local public health messaging targets this exact vector, advising communities to rigorously boil palm juice and immediately discard any fruit showing signs of bat bites. Despite these warnings, the physical overlap of agricultural practices and bat habitats ensures that periodic primary spillover events will happen. Because this initial zoonotic jump is an ecological inevitability, the entire burden of preventing a wider epidemic falls exclusively on early diagnostic interception. The challenge with early interception is that the pathogen easily slips past initial medical screening during the first few days of infection. A patient presents with nonspecific early symptoms: fever, headaches, muscle pain, and vomiting. To a triage nurse, this mimics dozens of common seasonal illnesses, but the virus is actively overriding the host's cellular machinery. This triggers rapid, catastrophic clinical deterioration, leading directly to acute encephalitis, or severe brain swelling. Simultaneously, the virus induces severe respiratory complications. Patients develop atypical pneumonia and acute respiratory distress. In critical cases, this cascade of neurological and respiratory failure progresses to seizures and coma within a 24 to 48-hour window. Confirming the presence of Nipah during these acute phases requires dual diagnostic modalities: RT-PCR testing from bodily fluids and antibody detection via ELISA. Running these complex assays creates a logistical hurdle. Handling samples with such a high case fatality ratio requires high-level biocontainment facilities, which are rarely located near rural outbreak sites. To solve this, the Indian Council of Medical Research's National Institute of Virology stepped in for the West Bengal cluster. They rapidly deployed a mobile BSL-3 laboratory directly to the region. This allowed all 190 contacts to be tested swiftly and safely in a fully contained environment. By compressing the diagnostic turnaround time, health authorities gained the crucial lead time needed to outpace the virus's long incubation period. Testing the contacts solved the intelligence problem, but the West Bengal cluster contained an extreme variable. Both infected patients were active nurses operating inside a healthcare facility. Secondary transmission of Nipah relies on close, unprotected contact with the bodily fluids of an infected person. A hospital ward is a high-risk environment for this to happen. The standard medical precautions used in daily hospital operations, basic masks and gloves, are entirely insufficient to stop it. Hospital administration mandated an immediate shift to rigorous droplet and contact precautions. This required fluid-resistant gowns, examination gloves, and total eye protection before stepping foot in the ward. The threat profile escalates further when a patient's respiratory failure requires mechanical ventilation. This introduces aerosol-generating procedures, which can suspend infectious particles in the air. Staff implemented strict airborne precautions, utilizing negative pressure isolation rooms and fit-tested filtering respirators to safely ventilate the patients. These uncompromising protocols extended everywhere. Even transporting a patient outside the ward required a team encapsulated in full-body protective gear. The strict physical barrier of these infection prevention and control protocols successfully severed the transmission network, preventing a nosocomial disaster among the hospital staff. Examining the official epidemiological evaluation of this outbreak reveals exactly how global health institutions view the event. This layered risk matrix from the World Health Organization presents an apparent paradox regarding the Nipah virus. At the subnational level, the risk is classified as moderate. This is driven by three factors: the lack of medical countermeasures, the probability of diagnostic delay, and the permanent presence of the bat reservoir. Yet at the regional and global levels, the risk drops to low. This rating is directly tied to the presence of rapid response teams and the resulting geographically bounded spread. In epidemiology, an outbreak expands when its effective reproduction number pushes past 1.0. India's rapid response infrastructure artificially forced that number down. Because of that localized intervention, there has been zero confirmed spread of the virus outside of India's borders. This One Health coordinated approach, merging animal surveillance, rapid mobile diagnostics, and strict clinical isolation, serves as a blueprint for handling priority pathogens. The speed, structure, and precision of the human systems deployed for containment ultimately dictate an outbreak's lethality, overriding the inherent biological traits of the virus.